On 15th of June in the morning time, this boy you can see on ventilator. This is picture taken at around 10:30 a.m. and at 7 a.m. at a village near Himmatnagar, this child was fine. He goes out to brush his teeth, and to his surprise, he puts his leg on a reptile or a snake, and that's what brings him to the ICU. So this happened exactly the day after, I was asked by Dr. Snehal Desai to talk about animal bites, specifically snake envenenation, scorpion sting, and your dog bite. I thank for this opportunity to interact with you all through this medium on online teaching. So my name is Dr. Khanjan Shah. I'm consultant pediatric intensivist practicing at Ahmedabad Sneh Children Hospital. So in next couple of minutes or so, I'll walk you through a few things. First, we'll be discussing about snake envenomation, and then we'll be discussing about scorpion sting, dog bite, and the other animal bites. That's what we'll wind up with. So coming back to this child, now this 8-year-old boy with absolutely normal past history or no significant family history, absolutely fine, and goes out in the morning time, gets a bite from the cobra snake, and then they were rushed to the hospital nearby. By the time they reached there, child had tosses, his voice had changed, and his breathing was labored. He was immediately intubated and was transported to PICU, and further management were done. So when we first received this child, his temperature was normal. He was tachycardic. There was no spontaneous respiration. He was paralyzed. Saturations were fine with bag and tube ventilation. Blood pressures were okay. Sugars were a little on the high side. Rest of the systemic examination for CNS, his pupils were equal reacting, but apart from that, there were no movement on the limbs or spontaneous breathing. So this is how we received this child. So I'll just pause at here and discuss in brief about how the snake bites presents and how we should be managing it. And then we'll come back to this child once again. So basically in India, we can see three kinds of or the varieties of snakes in India. First is the cobra or the kraits. Now these class of snakes are highly neurotoxic, and some of them also have a cytotoxicity. Coming to the second variety, the rattlesnakes or the vipers. Now these notorious snakes are known for causing severe hematotoxicity, which leads to DIC and bleeding, hemorrhage tendency, and stuff like that. And lastly, sea snakes. So these are common varieties which we see in India. And the kid we talked about was bitten by a neurotoxic snake. Now, how do we diagnose the snake envenomation? So, a high index of suspicion should always be there. I remember a child, where there was no history, no fang marks, and then just because child, it was very hyperacute event in the farm, and on the suspicion of that snake bite, anti-snake venom was given, and that child did well. So if there is history, collaborative evidence are suggestive of snake bite, you keep high index of suspicion. In a children who become suddenly ill, very hyperacutism, just like mechanical or vascular event, when with they are unsupervised in rural area, monsoon or pre-monsoon season, one should always keep snake bite as one of the differential in the patients who presenting with either paraneurotoxicity or hematotoxicity. If there are signs of snake bite then it confirms the diagnosis of envenomation, provided the other evidences are there, and that may include puncture marks that may at times be difficult to see, but they consist of either single or double or multiple puncture marks, or scratch marks may be there. Also, regional tender lymphadenopathy may also be there in certain snakes. And lastly, the features of elimination. So in next slide, we'll see how what are the different features of this particular thing. So first and foremost, we discuss about the local effects. Now you see a progressive limb swelling, blistering, discoloration, even bleeding, oozing, pain. So these are the local effects one might see when there is a snake bite. Certain non-specific features might headache, nausea, vomiting, abdominal pain, or unconsciousness. These would be non-specific or not pointing to any particular illness. But if you do not have diagnosis, keep a head index of suspicion when you have a child presenting with them. And coming to the specific features, coagulopathy, that means in form of bleeding from your mucosal surface, from your bite site, or whenever you are venipunctures or taking samples and there is a significant bleeding from those sites, is what one should think about the coagulopathy. Or neurotoxicity in the form of diplopia, ptosis, dysarthria, dyspnea, respiratory failure, difficulty in swallowing or breathing, slurred speech, etc., etc. It tells about the neurotoxicity because of snake bite. Myelitis also one should keep in mind. They may present with that, and later on, if not, uh, but not diagnosed on time, this would lead to multiple organ dysfunction syndrome, kidney injury, etc., etc. So keep these presentations in mind, and the when this is how you diagnose envenomation. Now, this one slide where if I summarize the management of snake and victim, keep these 7 things in mind while management. First is first aid for snake bite. What all needs to be done is what we should know. Immediate clinical management, ICU management, laboratory, what all the laboratory evidence or should be what investigation we should be sending. Anti-snake venom. So this is a specific antidote in a way, and that should be given. How it's to be given, how much we'll discuss that out. Supportive treatment, and lastly, systemic toxicities to be managed. So this is how 7 slides. Next 7 slides we'll discuss about in the management in the most practical way possible. So first and foremost is the first aid, and there's at the site of first encounter when you see a victim of snake bite. So there's mnemonic, do it right. So R is for reassure the patient. They should not be worried much, because not all snake bite are because of the poisonous snakes, and you have to reassure. Second important point which you should do is immobilize the limb. That is that the I is for immobilization, and do it as we do it for the fractured limb. You can use the bandages or clothes, and it should be not be too tight to block the blood supply, and compression should not be that tight. Go to hospital, and lastly, tell the doctor for any symptoms such as tosses. Whatever the symptoms have come up, you tell your doctor. So immobilization and going to the hospital for ASV and specific management should be the priority when you see such patient. Tourniquets were widely used by lay people, but then it has certain adverse effects like ischemic damage, ineffective venom flow, potentially increase the necrotic action. So, make sure that tourniquets are not that too tightly bound. Also, because we are discussing our first aid, then the pressure immobilization method also has been advocated, and as a reliable technique to basically inhibit the venom flow into the system. So you immobilize involve trying either creep bandage along the limb, like you do it for a sprain, that you should keep in mind. Incision, suction, electric shock, those sort of things should be avoided. Keep the patient quiet, and transport patient to the hospital. So this is the first aid which you should be doing. Reassure, immobilize, not too tight your tourniquets, and no suction, drainage. That don't do those practices which would waste time and might cause damage to the child. Immediate clinical management, like any other emergencies, you maintain the airway, give oxygen, respiratory support. Like in the case we discussed, you should give establish IV access, start IV fluid, and keep your pressure immobilization as by the time till you reach the hospital and where specific treatments can be offered. And do not remove the bandages till the ABC and other aspects are being taken care of. So this is what the immediate clinical management also you should be doing. Coming to the ICU management, and by the time you are giving the specific treatment, certain things also you should be parallelly looking after and managing it simultaneously. First and foremost, like any other emergency, as we said, airway and breathing, secure the airway, give the positive pressure ventilation, and make sure there is no hypoxia or hypercarbia. If there is any circulatory failure, so airway, breathing, circulatory failure in form of, then you give fluids, get an excess of central lines, start your pressures or whatever required. If there is coagulopathy like hematotoxic poison, snake bite, then avoid putting too invasive procedures like IV, central line, etc., because risk of bleeding is very high. Ongoing care, you observe the urine output and infection control, assessment of respiratory functions, tetanus immunization. So your ongoing ICU care must be at place. And many a time local assessment is being not being looked after. So make sure you check that, and any development of gangrene or all should be kept in mind. So this is the in general ICU management whenever a patient of snake bite lands into ICU. Now, next is what all the blood tests you should be sending. So basically here, what you send is uh, coagulation studies are of prime importance, where you send PT, APTT, CBC to look for the platelets. Basically, PT, APTT, and all would tell you if they are deranged, which we see in hematotoxic poisoning, they are at high risk of bleeding. At a place where there is no access to lab early, then this WBCT, so 20-minute whole blood clotting test, can be tried. As you can see in the picture, I have, just for academic purpose, for that child, I kept it next to that patient's bed, where you take blood in your sample, a tube, a vacute, and keep it for 20 minutes, and then you gently tilt. Now, if the blood is still liquid, and that means it is not clotted, that it tells me that there is an evidence of coagulopathy. So I have to be very aggressive in my management, knowing that child would bleed from any site possible. Apart from that, CBC, when we check for the hemolysis, my urine for myoglobinuria, or creatinine kinase of liver function, renal function, etc. If child is coming to you late, you might want to check all the organ function, as well as then you might consider getting echo done, chest X-ray, etc. So not for the snake bite, but in general, as in where you want to see the overall how much the child has been damaged because of this condition. Now, coming to the most important aspect and a very practical way of knowing how to give ASV, how much to give, etc. So basically, ASV, or the anti-snake venom, is immunoglobulin, and they are purified from the serum of horse or sheep. And how they prepare it, they immunize them with the snake of one or more species of snake. So as you can see in the bottle here, there are for each ml, how much of the snake venom is being neutralized of the 4 common snakes in India. So I'm not sure whether you can read it or not, but cobra snake, common krait, Russell viper, and south scale viper venom is what these ASP which we used helps. So when to give? So any, as early as possible, you have to give ASV if you know that the diagnosis is of snake bite. Now, if many times you're not sure about, then there's no, though there is a risk of anaphylaxis, but the risk benefit, if you see, and you have high index of suspicion of snake bite, consider giving ASV. You, as early you can give, but many times you can, if the child presents to you late, so whenever they presents to you, give at that point of time anti-snake venom. How to administer? So basically, The anti-snake venom, they are these ASV vials are stored at 0 to 4 degree and prior to reconstitution. It can be used up to 2 years from the date of manufacture, and it should always be given intravenous. Now, prepare the patient and clinical environment for potential anaphylaxis or anaphylactic reaction because of this particular product, because it is an equine or sheep product, not the human. Now, you have to reconstitute this antivenom powder with 10 ml of sterile water. Shake well and rotate it between the palms and hands till they are fully dissolved, and let the vial stand for serum to clear. Now the dose is for mild it's 5, for moderate 10, and severe 15 vials in both adults and children. So we gave to this child around 10 vials of anti-snake venom. Now, once those vials, you dilute them with 1 is to 10, and ASV test is now abandoned, though there is risk of anaphylaxis, but with all the preparation and risk, you have to give this. So you start infusion very slowly, carefully, observing the patient for reactions like rash, tachycardia, hypotension, bronchospasm, etc. And then gradually increase the rate and give it ideally over 20 to 30 minutes, but usually we give it over for an hour or so. Around 20% odd patients would develop reaction either early or late. And anaphylaxis, you keep the orders ready. If you have any sign of anaphylaxis, how much adrenaline to give, in what how much the volume of normal saline, steroids, your avil, etc. should be written prior to giving, or at that time, because in emergency there may not be that much of time to go and run for the things and calculate the dose and then give. So it's better to keep them prepared, and you have to give it as early as you see the first sign of anaphylaxis. So this is how ASV is to be administered. So dose around 10 vials, reconstitute it with 10 ml of sterile water, and then it dilute it and give it over 30 minutes to 1 hour. Coming to the supportive treatment, like steroids or antifibrotic heparin, they should not be used. Make sure there is, all the practices to prevent nosocomial infection are at place, that you should not neglect or ignore. And the supportive nutritional aspects, sedation, analgesia, all those things should be checked like any other ICU care. So specific treatment is ASV, but an ongoing ICU as well as supportive treatment should be plays a vital role in overall outcome of these patients. And lastly, if there is systemic toxicity, for example, if there is coagulopathy, then you have to give blood products for bleeding. You might need to require clotting factors, so FFP, cryoprecipitate, those. So intimate the blood bank in advance that blood products may be required, and you might need to give it for the patient. So coming back to our child, so this child was, I'll continue the story. So when very first child shouted at home, the parents rushed and they could see the snake running away. By mistake, this child stepped on the foot of, stepped his foot on the snake, and that bit on his legs. As we saw in the very first picture, even fang mark was there. So they rushed to the Himmatnagar, and in between, child started getting symptoms. At Himmatnagar, the very first encounter by the team was that they secured the airway and they started anti-snake venom the way we described. Even during the transport, the child had ASV, and they gave few extra ASV vial to the family, and that which we could use it when the child arrived with us. So after 24 hours of, and the child power and everything improved, we could get him out of the ventilator. At 72 hours, he was out of the ICU, and on 4th day, we could discharge him. So if you timely manage this particular condition, then chances of good outcome are very high. Now coming to this second case, a very interesting story. Now this a 5-year-old boy from a village near Surendranagar now, and he sees the scorpion down the bed outside his farm, and this naughty fellow tries to play with it. He takes this scorpion in his hands, and he thought that he what I don't know what he was thinking, but he started playing with that scorpion. And that what scorpion must have felt. And he bites with his peg, and now this child within few minutes starts getting symptoms, and by the time he reaches to us, his heart had already started failing. So there are more than 100 species of scorpion are there in India, but two are more common and they are frequently encountered. Scorpion are basically active at night, and they inhabit in warm and moist climates. How they act is that this venom contains a toxin which inhibits the sodium channels, as well as it blocks the calcium activated potassium channels. Now, once these channels are blocked, what happens is there is an excessive activation of sympathetic and parasympathetic nervous system, which leads to massive release of catecholamines. And this autonomic storm is responsible for the features or the manifestation which we see out of this scorpion stings: tachycardia, increased myocardial consumption, hypotension, coronary vasoconstriction, etc. Scorpion sting also venom also suppresses insulin secretion, and we see hyperglycemia, hyperkalemia, etc. And most of the deaths are due to cardiopulmonary complications such as heart failure, myocarditis, and acute pulmonary edema, if not managed in time properly. So effects of elimination, if we discuss in brief, local effects: pain, swelling, ecchymosis, tissue necrosis may be there. Coming to systemic or neurological effects, autonomic storm would bring profuse perspiration, tachypnea, tachycardia, excessive salivation, vomiting, priapism, etc. Also, very non-specific, wide variety of neurological symptoms like agitation, rigidity, tremor, twitching, encephalopathy, convulsion, cerebral edema are described with a scorpion sting. Coming to the cardiovascular system effect, autonomic storm leads in intense tachycardia, leads to excessive cardiac work. There is also coronary and peripheral vasoconstriction, which leads to increased afterload, and again the failing heart has to pump harder against increased systemic vascular resistance. Initially, there will be an hypertension for 4 to 6 hours, and then there will be hypotension, cardiogenic shock. Now, that cardiogenic shock will lead to multiple organ damage, organ failure, and eventually death. So, basically, that is what how in RS there will be a pulmonary edema and might need a support. And other, like there will be pancreatitis, hyperglycemia, hyperkalemia, DIC would also be seen with the scorpion sting. Now, treatment of scorpion sting, if we discuss one by one. First and foremost, local wound, just clean the wound with antiseptic. You can give analgesia, immobilize the limb, do the cold compresses, etc. Avoid narcotics because they all have synergistic neurotoxic effect with the venom. So don't use fentanyl or morphine as an analgesia, but you can use NSAIDs for the pain. Also give tetanus toxoid vaccination. Supportive measures like airway, breathing, circulation, you have to manage it properly. Intubate the child if there is increased work of breathing, cardiogenic shock, etc. In the fluids, be very cautious. Don't push the fluids without knowing the what's the exact status of cardiac function. You might, if the heart is failing, the excess volume would not help much, and in fact deteriorate the condition of the child. You might have to use insulin if there is uncontrolled hyperglycemia. So supportive measures, infection control, tetanus toxoid, etc. should be there. Now coming to antivenin, I have not used to be honest. I don't think it is available also. But coming to the prazosin, this is one drug which is a selective alpha blocker and has it helps in the management of scorpion. How to give and all, we discuss about that. To remember that steroids, digoxin, glytic cocktail, or other heparin, those stuffs has no role and should not be used. Coming to prazosin, so basically prazosin is an alpha blocker, and basically it's an antidote to the action of scorpion venom. So it will antagonize the effect of catecholamines and it will reduce the cardiac afterload and hypertension without increasing the heart rate. So that's why it should be given as early as possible. Dose is around 30 microgram per kg per dose. You can repeat it after 3 hours, and then every 6 hours you give until you see the features of autonomic storm have reduced or subsided. At max 4 to 5 doses are being required in children. And other options like labetalol, or you can use because it's a combined alpha and beta blocker. Hydralazine and nifedipine might be used if there is an uncontrolled hypertension. Also, uncontrolled hypertension may need initiation of vasodilator drugs like sodium nitroprusside, nitroglycerin. In fluid intake and output should be optimized very cautiously. Dobutamine and other inodilators may be used if there is a cardiogenic shock. Patient may need ventilatory, either invasive or non-invasive support when they are, have a cardiogenic shock. Now, late presentation, delay in prazosin, there is pulmonary edema, arrhythmia. These are the late features, and they have poor prognosis overall. So basically, you have to keep in mind that, be very aggressive in your management. As in when you get the child, make sure your hemodynamic support, your, airway, breathing, work of heart to optimize, all should be very aggressive. Then and then the management would get the positive outcome. So this was about this scorpion sting, and that child who fond of playing with the scorpion. Now, when we received him, his ejection fraction was only 10%. He required to be put on a ventilator for a few days, and then gradually he was managed with supportive as well as prazosin for 3 or 4 doses, and then gradually on day 3 or day 4 he was out of ventilator, and it took 7-8 days for him to go home after the extubation, and still his cardiac function remained low for quite some time, and then he was fine. So whenever you see a patient of scorpion bite, this is how one should be managing them. Next couple of slides will discuss about the dog bite. Significant proportion of, if we talk about the statistics, significant burden is there about the dog bite, and rabies is a fatal disease, invariably fatal, and it can be prevented if we give timely prophylaxis. Also, wound care and active and passive immunization, which we all should know following a dog bite. Rabies also can be caused by cat bite or bats or foxes bite as well. So management of wound and all is same. So we'll discuss that about in next few slides. So before we go ahead, we have to categorize the wound in the category 1, 2, and 3. And based on that, the management or what treatment principle are to be used given by the WHO. So category 1 is just a touching of or feeding animals, animal licks on intact skin is what is category 1. Category 2 is there when there's nibbling of uncovered skin, minor scratches or abrasions without bleeding. Whereas category 3, where there is a significant exposure, where single or multiple transdermal bites or scratches are there, the contamination of mucous membrane or broken skin with saliva from animal licks, and exposure to direct contact with bats. These all are considered as category 3. So coming first, the local wound management. First and foremost is that, in first aid procedure, you have to thoroughly flush and wash the wound with minimum 15 minutes with soap and water, or povidone iodine can also be used. Followed by, you have to irrigate the wound with saline using 50 ml syringe and 20 gauge IV cannula. You just have to flush the wound. You have to give tetanus toxoid. Daily dressing may be required, and suturing is usually not advised, but if that has to be done, you have to the immunoglobulin are to be infiltrated. Tetanus prophylaxis in form of TT plus tetanus immunoglobulin one has to consider. Tetanus toxoid for incompletely immunized patient or whose last immunization was more than 10 years ago. Whereas TIG, tetanus immunoglobulin, is indicated for very dirty wounds, especially in incompletely immunized child. So this is how you and the prophylactic antibiotics one might consider using. So local wound management is same for all sorts of bite, including dog bite. Now, if there is a category 1 wound, which we discussed, that just you have to do a wound care and no prophylaxis is needed. If there is wound category 2, there appropriate wound care and immediate post-exposure prophylaxis, that is vaccines one should start. And if it is category 3, there wound care, then vaccine as well as active as well as passive immunization should be instituted as early as possible. So we'll discuss about active immunization first. So vaccine, human diploid cell vaccines are commercially available and the commonest agent used. They vaccine, while they should be stored between 2 to 8 degree after reconstitution, and it should be used as soon as possible. Make sure you give it over the deltoid region or the anterolateral thigh. Do not give on the gluteal region where absorption is very unpredictable. The schedule is on 0 day, 3, 7, 14 and 28 day. SN regime is what is being used, and that you have to give. Coming to the passive immunization, where now it takes time for vaccine to induce antibodies. So meanwhile, one has to consider giving passive immunization in category 3 wound. Human as well as equine immunoglobulins are available. The dose of human immunoglobulin is 20 international unit per kg, whereas of equine is 40 international unit per kg. You have to use that, whatever the amount comes up, all that amount has to be infiltrated again around the wound, so that use all the immunoglobulins in the wound. Now, if after doing that, if the volume remains, you might consider giving it to IM at the other side, but use most of them. So this is about the passive immunization. If the patient has already received active immunization previously, then you don't have to give. Like if in the past the patient or the child has received post-exposure prophylaxis, then you don't have to give the passive immunization. So this is about the passive immunization. So this slides tell that what you should be doing. So as you can see, category 3, wound management, rabies immunoglobulin and anti-rabies vaccine. So this is all from this presentation. So take home messages from this presentation is that whenever there is a snake bite or have high index of suspicion, when absolutely normal child presents with hyperacute event or undiagnosed, keep a high index of suspicion. Make sure you immobilize before transport. Your ICU team and management is apt, and anti-snake venom you have to give. So this is about snake bite. Scorpion sting, make sure prazosine and all you give it in time, and routine cardiogenic shock management is at place. And lastly, in dog bite, active and passive immunization and wound care should be optimum for the prevention of rabies. Thank you very much, friends. Thank you for your time. And if you have any questions, you can contact me. Thank you.